ورجعنا لكم تاني في حلقة جديدة من برنامجنا بودكاست بالسكر. أنا هاني نعيم، استشاري السكر والغدد الصماء. أكلمكم هنا من بوخارست، من مؤتمر النيورودياب، مؤتمر الجمعية الأوروبية لالتهاب الأعصاب السكري. ويسعدني أن يبقى معايا النهاردة صديقتي وأستاذتي الأستاذة الدكتورة كريستين بروك. Good morning, Professor.
Good morning.
Will you please introduce yourself to the people of Egypt?
Oh, I'd love to. Good morning, Egypt. This is Professor Kристина Brock from Aalborg University and Aalborg University Hospital in Denmark.
Okay. And what's your specialty?
So I work with the internal nerves, the so-called autonomic nervous system, regulating the inner organs so that they can control the environments that not only internally but also externally, and adapt to those in order to keep the body in balance.
Mm-hmm. Okay. And today I wanted to ask you about the control over the gut.
Yes.
Recently, I have had several patients who come to me with what's called gastroparesis diabeticorum or the diabetic paralysis of the stomach.
Yes.
Okay. In Arabic, شلل المعدة السكري. Okay. What do you have to say about this?
The first thing I have to say is that a lot of the patients with the long-term diabetes, they suffer from gastrointestinal complications. And it is true that there has been a lot of focus on the gastroparesis or the lack of emptying or the delayed emptying of gastric content into the duodenum. However, it's not limited to the stomach. It's actually throughout the whole gastrointestinal canal, going from the mouth to the anus, and there's complications in every segment of it.
Mm-hmm. Okay. So if we start with the stomach and then go down, okay.
Yes.
When I do get these people, first thing I do, after I take a very thorough history, okay, in order to confirm the diagnosis, I ask for a nuclear scan. Okay, basically they eat eggs with a radioactive label. Okay, is this test safe?
It is a safe test to do scintigraphic recordings from the stomach, yes. The problem with this, and this is the golden standard for actually diagnosing gastroparesis, but the problem with the test is that there is really, really poor association to the symptom burden that the patient experiences. So you can have a patient with a really high symptom burden, but a normal emptying test, and vice versa.
Okay, so when I do this, this is the first test I do, and then I put them on medication.
Yes.
Okay, and the medication, generally speaking, works a bit for a while. I put them in small, frequent meals, etc., etc. Generally speaking, like we don't get such wonderful results, but we do get some results. Patients feel better. Okay, and then one of the things we do, we put them on the more liquidish diets, because generally it's a problem with solids rather than liquids. Am I correct?
Yes, you are correct. But I think at this point we also need to acknowledge that gastroparesis is not just caused by one impairment of the gastric control. So if it's a lack of accommodation or the gastric wall's ability to actually be flexible in response to a meal, then small meals, liquid meals, as you said, that would be the type of intervention or treatment that you need. But if you do have contractions and if you do have a normal contraction pattern, but the contractions are not large enough in their amplitude to actually move the food forward, then you can also use prokinetics such as procaloride.
Procaloride. Okay.
Yeah.
Okay. So that's one way. Okay. We used to use metoclopramide. We used to use demperidone. We used to use that. The procaloride, I know, had a very good study.
Yes.
Okay.
I did.
But do the rest work?
If
The rest, does it work?
so, domperidone I think works really well in some patients, but you're going to be careful with the QR
Yes. Okay.
intervals.
Okay, this is some form of arrhythmia. This is an irregularity of the heartbeats, which can be caused by domperidone or motilium. Okay, and that's why it's disappearing in most countries.
Yes.
Okay,
Yes.
and so that's about the first thing.
Yeah.
Can the opposite happen?
Oh, yeah. You can have
Rapid gastric emptying.
Yes. You can have that, and that would actually be just as bad, because then you get dumping symptoms. So
Okay.
you have
You
uningested.
just said you just dropped the bomb.
Yeah.
What's dumping syndrome? Tell me.
Yeah. So you have uningested food coming into the intestines, and that would cause, that a lot of liquid is drawn to the food content there, and it will give you really, really severe symptoms of nausea, and you feel bloating, you feel pain, abdominal pain, and it's a really, really serious symptom burden that you experience at that moment.
Can you lose consciousness?
Yes, you can actually. That's true.
Okay.
That's true.
So you can just eat something and then suddenly, a few hours later, suddenly fall.
Yes, that would be the ultimate consequence.
It's very bad. And what do we do to control dumping syndrome?
So the most efficient way to do it would again be just like we were talking about, small frequent meals and liquid meals. Liquid meals are really good in this case. Yeah.
Medication.
So if it's rapid, we know from the use of, for instance, GLP-1 receptor agonists that could actually delay the gastric emptying. So in case of really rapid emptying, I would suggest the GLP-1 RA.
In low doses or...
Yeah, exactly.
Okay, this is what we do, by the way.
Yeah, you do that already.
Okay, and so this is concerning the stomach. If we go further down into the intestine, we can have bacterial overgrowth.
Yes.
Okay, what's bacterial overgrowth?
So small intestine bacterial overgrowth means that because there is a delayed emptying, you will have a specific part of the microbiota that...
Microbiota is the bacteria inside the gut, inside the intestines.
Yes, okay. That's right. So you will have certain species within the microbiota that actually overgrowth, that kind of have the surroundings for...
Okay, so basically,
for increasing their number.
Is it normal to have bacteria inside your intestine?
Yes. I mean, you have so many different species. You have bacteria, you have fungi, you have you have all the kind of microorganisms in your gut.
And they live inside your intestine, and then if we have a problem, the bacteria grow too much. Okay. And then what happens when they grow too much? So
usually they produce gases, and that will cause really severe symptoms also from the upper gut. Yeah.
Okay. And so this is concerning the bacteria inside the gut. And then if we go further, okay, to the colon, what can we find?
So we know as soon as the food content is passed into the colon or into the circum, the very proximal part of the large intestine, that's where the short-chain fatty acids are broken down, and that will lower the pH milieu in that segment. In
English, please.
In English. So as soon as the content is moved into the upper part of the large intestine, the so-called circum, that's where starch is broken down into little fatty acids.
Okay.
And that will require a certain internal milieu inside the environment.
Okay.
Yeah, inside the gut. And we know from people with diabetes that it's not as acidic as you would want it to be, meaning that there is an alteration of this breaking down of the food content. Furthermore, we know that a lot of people experience constipation because the contractions are less productive. And again, that's because the enteric nervous system within the gut
The
wall.
nervous system coming from the autonomic nervous system, which is inside or around the intestines and colon.
Yes.
Yes.
That's right.
Okay.
And we sometimes call it, the gut's brain,
Okay.
because there's a network of neurons that is connected, and the number of neurons actually exceeds the number of neurons in your brain. So it's very, very vulnerable.
So you have more thinking going inside your intestine than you do in your brain. This is very, very, very productive.
Yeah, it's very productive, but it's also vulnerable. And it's vulnerable especially in people with diabetes because of the hyperglycemia. And all these nerves, little nerve endings, and the synapse between the nerve endings, the communication between the nerves, is vulnerable to hyperglycemia. And that's...
So high blood sugar damages these nerves.
Yeah,
okay.
It does. And that causes motility disturbances, but also disturbances in secreting hormones and, for instance, enzymes that you need to break down your food.
Okay. So all of this is wonderful. I really doubt anyone will understand it, but at the end, doctor, what do I have?
Yeah.
Okay, what should I feel? If I feel, what should I come and see you?
So most of the symptoms with gastroenteropathy is nausea, it's ultimately vomiting, it could be bloating, it could be that you have early satiety feeling, it could be abdominal pain, it could be diarrhea, but mostly constipation. But also it could be, and that's one of the most devastating symptoms at all, that's fecal incontinence.
Okay, this means that you can be walking and suddenly you have fecal matter just dropping out.
Yeah, that's the
More or
very
less.
ultimate, or you need to reach a toilet within very, very few minutes. I mean, it's an urgency, and you couldn't feel it coming. And that's probably one of the worst complications to gastroenteropathy.
It's horrible.
Yeah, it is horrible.
Okay, and speaking about fecal incontinence, we can go to the front.
Yeah,
Okay.
Yes.
And here we can have urine incontinence.
Yes.
Okay.
Exactly. Yeah.
And first, we have overactive bladder, which is you tell me.
So the overactive bladder is where when you have to go to the toilet very, very often, but you don't really have urine.
The amount is small.
Yeah.
And how much time can you wait?
Oh, for some people it's even every 30 minutes or something like that.
No, like if I get the feeling I need to go to the toilet.
Then it's urgency.
Immediately.
Immediately, yes.
Okay. And then I get a few drops.
Yes.
Okay.
Yes.
Okay. But
you can also have the other way around.
yes.
That you have urine.
Future-wise,
Yes.
what happens next?
Yeah, I mean, if you have urine retention where you cannot empty your bladder.
So basically, we have a full bladder. Okay, that's so full and it cannot contract.
Yes.
Okay.
Yes.
And the excess urine just
leaks out.
leaks out.
Yes.
Okay. Speaking of, we've started a diabetic incontinence clinic back home at the Diabetes and Neuropathy Center, our clinic. And we're using percutaneous tibial nerve stimulation.
Yes.
Okay.
Yeah.
The new device thing. And actually, we're getting very good results.
So it's the sacral nerves. You're stimulating
No,
the
we put it inside in the leg, just above the foot.
Yes.
Okay, and we're giving electric stimulation from there, which goes up to the sacral nerves.
Yes.
Okay,
Yes.
up to and it starts to reset the connection with the brain, and we just started it for less than 2 months ago. Like we're starting with our first patients. the very strange thing, because like when I went into formal training for this, I was told like you should start to see results after the 12th session. Okay, with our people, I'm seeing positive results. Like people are coming back to me and saying, they do these urine diaries, okay, and they say to me that the number of urgent times they need to go to the toilet has halved, and this is after 3 sessions.
Oh, that's amazing.
Okay.
And it's really, as you say, it's about the convergency in the sacral segments.
Yes.
So it's stimulating
Sacrum is the lowest part of the
lowest
spine.
part of the spine.
Okay.
And that's where you also have the autonomic control of your bladder and of your lower gut.
Okay. And so, from my experience, PTNS works.
Yeah, but I mean, for these people, you want to do everything to help them.
Well, you see, okay, because when we started, basically, we didn't have much to do.
No.
Okay, so having something with such positive results.
Yes. And I think the beauty of these non-pharmacological interventions is that they comes without side effects.
Yes, definitely. Definitely. And no interactions and no other problems. It doesn't make them sleepy. It doesn't make them drowsy. It doesn't make their eyes blur.
No.
No, I really love it.
Yeah. So these electric modifications or modulation of the nervous system, I think that they have huge potential for the selected patients and for those that can actually benefit from it. I can only say go for it.
No, I really love it. I'm someone, you know me. Okay?
Yeah.
I'm someone who's very difficult to impress. I'm really impressed.
Yeah, but I think you should be with the numbers that you tell me. Yeah, you should be. Yeah.
Anyway, so this is as far as the gut goes and the bladder goes. Okay. Is there anything more you'd like to tell me about the autonomic nervous system other than it's fascinating and it's your love and all of this stuff?
So I think it's under-recognized in our clinics that this beautiful autonomic nervous system that is beyond your will, you cannot control it by your brain. I think it has, for decades now, it has been suffering that nobody really paid attention to it. And what I feel is that it's coming back into consciousness also in clinics. And I think it really deserves it because it's the organ system or the nervous system that really provides us with the balance in our body.
I feel you're talking about your son.
Yeah. Well, maybe.
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 Speaking of, what's your latest research which you came with this year? What are you working on now?
So what we have done recently is that we've worked about vagal nerve stimulation. So we're stimulating the parasympathetic branch of the autonomic nervous system in order to enhance the cholinergic anti-inflammatory reflex in patients with lupus and high level of inflammation.
Okay, so again in English.
Yeah.
Okay, the vagus nerve.
Yes.
بالعربي العصب الحائر, which is the nerve which controls the heart. Okay, and this is what gets damaged in cardiac autonomic neuropathy. It's the nerve which controls the upper gut. It's what controls the stomach and the intestines. Okay, so it's that one. And you're giving it electric. How are you stimulating electrically?
Yeah.
Okay.
So just like you were telling, just
like the PTNS I was talking about.
Yeah, more or less the same. What we do is that we stimulate the vagal part in the cervical area on both sides of the neck.
So you stick a needle inside there?
No, we don't. It's transcutaneous. It's non-invasive.
So it's on the skin.
On the skin.
And you start giving him electric impulses.
Yes,
we
do.
And this decreased inflammation level.
Yeah. So the vagus has so many different actions, and one of the actions that we didn't talk about now is that it can also lower your body's inflammation level. And that's done through activation of something called the cholinergic anti-inflammatory pathway. And it actually lowers the level of your systemic cytokines and inflammatory.
Cytokines are hormone-like things which are secreted in order to push inflammation or growth or something of the sort.
Yes, that's right.
or death. Okay, it works on always depending on what type are we talking about.
Exactly. And I think it was put up like 2 decades ago that it really had these anti-inflammatory properties by stimulating. And we have brand new data in a population with lupus erythematosus. And those are characterized by having a really high level of inflammation. And we have beautiful data now showing that we can lower the inflammation and actually enhance the patient-reported outcomes.
So it does have a symptomatic effect.
It does, and it's on fatigue, which was our primary endpoint. And people, they feel less sleepy. They feel that they're more awake after they have gone through this intervention. And we believe it's because it lowered the inflammation
right
in
now,
the body.
as you're talking, I'm thinking about fibromyalgia.
Yeah, fibromyalgia could also be an intervention group. We love the group of the lupus because it's such a specific disease, and we know exactly what's going on
You
with.
have how many lupus patients are there, and how many fibromyalgia patients are there?
Yeah, there could be more fibromyalgia patients, definitely.
Yeah, definitely, much more.
Yeah, definitely. But the problem with the diagnosis is that it's a little bit unspecific.
Well, if they will, I have never seen a fibromyalgia patient who didn't have high inflammatory markers.
That is absolutely true. That's absolutely.
So, okay, if this works, can I refer you patients from Egypt?
I'm afraid we cannot do that, but I'd love to. But it's an experimental treatment, and we cannot use it in the Danish healthcare system at the moment.
Too bad.
Yeah.
Anyway, I hope it works and you approve it, and then it can enter the healthcare system. Okay, and till then, so I'm very happy I was with you today. I'm very happy for all the wonderful information you told us, and on behalf of the people of Egypt, I thank you for your time.
Oh, thank you so much, and thank you for
Professor.
inviting me.
Thank you, Professor.